We're now with the Hospital Authority, and I'll note that Councilman Stein and Councilman Pridemore are with us. And Joe, if you could introduce yourself and your colleague and make whatever budgetary presentation you like, but I think maybe you should start with, if you want a suggestion, introducing yourself to the folks in Nashville and telling us a little bit about yourself.
Okay, thank you, Mayor. My name is Joe Webb. I'm the CEO at Nashville General. I come to Nashville General from Memphis, Tennessee, where I've spent a number of years working in the healthcare system there. I'm a graduate of the UAB Healthcare Administration program, and a number of years in hospital operations, and I feel very privileged to be providing leadership to this historical institution, Nashville General, here in Nashville. This is our CFO, Bob Lonas, here next to me. And I will jump right into information on what we're presenting on here today, the budget request and on the Hospital Authority. Some of the accomplishments that I'd like to just touch on real quick over the last year. We've been able to receive federal public hospital supplemental funds for the 5th consecutive year. We've had significant enhancement in our imaging department there at the hospital. We certainly like to thank the authority for allowing us to do that. In our MRI, state-of-the-art MRI, as well as cardiac catheterization unit. We'll be going live with our EMR, our electronic medical record Paragon system in June. And another certainly appreciated resource that we have there at the hospital. And we also decided to utilize some of our rooms as private rooms as opposed to semi-private rooms, which in the market is more acceptable, and the community is certainly more receptive to that. And we've experienced higher utilization certainly since that time. The key areas of our goals there are 4 of them: grow revenues in hospital and clinic operations, to improve payer mix in hospital and clinic operations, and to change the cost structure of hospital and clinic operations to be more conducive to creating an expanded base of revenue. And I say change or modify the cost structure as opposed to reducing costs, because that's not always, sometimes that's a misnomer. You don't really reduce the cost if you are going to apply those resources, again, to activities and initiatives that are going to be more conducive to expanding your revenue base and giving you a better margin. And lastly, under our goals, to deliver high quality and more abundant services to the community. And beneath that, we have some specific tactics and strategies that I won't get into all of those. But I'll be happy to answer any questions. There are a couple of comments that I do want to make in addition to that. One of the things that we want to do is to look at a modification of the policy of the way we provide services to our indigent population. We do provide A and B, parts A and B, meaning facility as well as professional fees, coverage for acute inpatient days, major invasive procedures, minor procedures, extensive stays in our ED in lieu of some of the correctional mental health facilities for behavioral health patients, chemical dependency patients, and intoxicated patients. These are somewhat social issues that we could probably gain a lot of momentum with by putting them on the table as social issues and addressing them. So the model for providing charity care in Davidson County is something that we would probably benefit by taking a close look at and updating to certainly to the paradigm shift in healthcare that's occurred. A couple of the things that we will need to do is look at a budget for the charity care that we can provide reasonably and discuss or negotiate or whatever a reasonable subsidy to help to achieve that. We need to make sure that we're eliminating any unnecessary waste and ill-advised resources. So we need to be really diligent about that. And we need to excel in some areas. Customer service, high quality and safe environment for our patients, efficient throughput, and inpatient ambulatory services. And participation and cooperation with Meharry, full engagement between both organizations. We need to work on creating an integrated healthcare delivery system and utilizing population health management model as our framework. I'll be happy to answer any questions.
Okay. What, can you talk a little bit about the census at the hospital, how the number of patients you've been seeing and how that's going?
I think that's going really well. Today, we have 67 patients in the hospital. Both of our floors, our telemetry floor, as well as our medicine floor, are both at capacity. And our ICU is certainly doing well. We have a higher number of patients in our postpartum and labor and delivery, so the volume has picked up. I think that that has a lot to do with the programming initiatives that have been put into place and distinct identification of those levels of care.
Okay. How is the hospital affected by the recent decision by the legislature not to expand Medicaid? How does that impact what you do?
Well, obviously, we would have had more opportunities to get paying patients. What that would have really done would have been to give the patients a better selection in who they actually utilize. It doesn't necessarily always mean that you're going to get all of those patients because they will have a better option. So what we have to do is focus on our level of services that we're delivering, the quality of care. So regardless of what type of plan takes place or goes into effect as far as expanding Medicare or the population, we've got to be prepared both internally and externally to service that population. Now, I'd be remiss if I did not say that I was disappointed to see that happen. But, we have to persevere and do what we need to do.
Play with the cards you're dealt. Yeah.
That's right.
In terms of other sources of funding, whether federal or state, do you feel pretty confident about where you are now in terms of continuation?
I do, yes. I do. We're going to continue to obviously provide a high level of care to the indigent population. We're going to continue to deliver more efficient services. So what we want to do is to create a better throughput mechanism so that we're able to advance in the concept of population health management. So.
Okay. One of the more recent things, too, along those lines, Mayor, is that they're looking right now to try to implement a permanent dish payment for the state of Tennessee, which we for years have not had a permanent one. That's actually pending right now in legislation and will be reviewed in the next month. That would basically, I think it's a 10-year guarantee at least, but that would be about a guarantee of $2.5 million to the institution. So that's pretty critical. So that's a welcomed review.
Does that look good up on the hill?
Yeah. As far as I know, it is. Right.
Rich?
Let's. I think it's important to talk about a little bit on the subsidy side of things. So essentially, what the hospital's asking for is a flat subsidy from the city this year at 35 million. I think what's important to point out is. This year, there's been a little bit of a transition. Obviously, Dr. Webb's here, which is part of the transition, but in terms of transitioning out of the nursing home business and out of the assisted living business.
Right.
And so there's been some costs associated with that have been borne in this year's budget, and some of which will carry over into next year's budget. But effectively, what that means is that should the subsidy stay flat, it would mean more money specifically for General Hospital in this year's budget than what we had in prior year's budgets. Is that right, Bob?
That's correct.
That's correct.
That's correct.
So I think it's, as we talked about the transitioning of the city away from those services and letting the private sector operate that it does sort of create the potential for money to operate the hospital on, hopefully reduce that over time, but it is more money for the hospital in that budget for next year.
And is that money that we currently sort of have obligated, or is that new money to deploy into something else that would sort of generate some of these goals? Do you know, Bob?
It would be the latter.
So we'll be an example of that. I'm assuming that we'll try to generate more revenue off whatever those dollars are.
Again, I think in following up with what Dr. Webb said about population health, there's some infrastructure management-wise that we need to change to be able to get into that realm. The value-driven healthcare versus just the fee-for-service reimbursement methodology and all that. He mentioned working collaboratively with Harry. We're looking at joining up some resources that can be shared. There'd be new resources, someone like over clinic operations that could help. So I think that's basically what we're looking for, is to be able to utilize that additional funding to help this transition, put it in place for next year. So we'll gain traction for the years downstream.
All right, with the priority being revenue generation, right? And whatever you do there, right?
Absolutely.
I mean, I think it's just an important
Yeah,
point
it's
to emphasize, because it's
That's different than we've done in the past.
different than we've done in the past. And this time next year will be completely gone from the nursing home business, no subsidy, which then the then mayor, the then administration can decide whether they take that money and reduce the subsidy, or if they feel comfortable, redeploy it for other purposes at the hospital. They're in a position. They're in a position to be able to make that decision where, because of the decisions that we've made over the last several years to essentially get out of the senior living business.
Right.
Okay. All right, well, Dr. Webb, welcome to Nashville again, formally here, and thank you for leading the hospital, and thank you for the important work you do, and we'll do our best here, and we appreciate the presentation.
All right, thank you.
Thank you.